All right, it is 11:02 a.m. Central Time, so we're going to get started today. First off, I want to thank you all for attending our From Micro to Macro, the Importance of Trauma Clinical Data webinar. Today, we'll be speaking with Q-Centrix expert and dedicated advisor Beth Ann Mendez on how clinical quality data plays a role in trauma programs, both at micro and macro levels. And we'll also share some challenges, best practices, and future trends in trauma clinical data. My name is Christina, and I'm a part of the partner experience team here at Q-Centrix, and I'll be your host today. I'm going to quickly review a few housekeeping items before we begin. So first and foremost, all participants have been muted to maintain the quality of today's discussion. If you have a question for our presenter, please submit them to the Q&A button located in your participant controls at the bottom of the screen. And if you see a question you'd also like answered, feel free to give it an upvote or a like by hitting the thumbs up button below that question to help us prioritize those questions when we get to the Q&A time at the end of today's discussion. If we do not get to your question during the live webinar time, we will follow up with you via email afterwards. If you have to jump early from this webinar or would like to refresh your memory or share this discussion with a colleague, this webinar is being recorded and will be shared along with our case study, Brady Memorial Hospital achieves a concurrent trauma registry via email within the next week. And finally, once our webinar concludes, a link to fill out a quick post-webinar survey will appear in your browser and in the chat box. And we would greatly appreciate your participation so we can continue to provide you all with the best emails and events possible. And that is it on housekeeping. So without further ado, I'd like to introduce Beth Ann Mendez. Dr. Beth Ann Mendez comes to Q-Centrix as a highly knowledgeable registered nurse with 27 years of experience in the acute care setting. She has a diverse critical care background, including trauma, neuro, and surgical ICUs. She is a licensed advanced practice nurse holding a critical care specialty certification. In addition to her work with Q-Centrix, she also serves as an adjunct graduate program professor. Beth Ann, welcome.
Thank you. Thanks for having me today.
All right, so with that, let's get started today. So I spoke briefly about your background just now, but could you please tell us a little bit about your background and your experience in using trauma data?
Sure. So I was a bedside nurse for about 14 of my 27 years in nursing. Most of that time was spent in a level 1 trauma ICU, where I served as a bedside role and trauma responder. I moved into leadership after a while, and in the leadership roles, I had a number varied in service, from education to professional practice and quality to operational leadership. And I really had the opportunity to utilize data to improve processes, improve patient care. So excited to talk about it a little bit more today.
Yeah, that sounds like some incredible work with a huge impact. Can you talk to me about what led you to your transition to your role here at Q-Centrix today?
Sure, absolutely. So when I was on the hospital side of things, I often had a plethora of knowledge and lacked data, or I was, data rich and knowledge poor, and meaning that I either had a lot of knowledge, but I couldn't substantiate or quantify it with valuable data, couldn't find the data, wasn't accessible, or I had a lot of data, but I didn't have it in a meaningful way that I could really derive a lot of knowledge out of that. And so, I found Q-Centrix, and I found what their mission is all about, which is, really kind of closing the gap on that. And I was excited to be part of a solution and part of an organization that's really driven to, getting the highest value out of data and having an impact on, the quality of healthcare that's delivered.
And you've also had multiple roles here at Q-Centrix, right? Can you speak to the transition in your work here?
Yeah, absolutely. I started with the business development role, and that was foundational into learning, all of the great opportunities and partnerships that we have at Q-Centrix. I was able to explore aligning our solutions and work with organizations and helping to form relationships. And now in the DA role, I kind of get to expand on that just a bit more and really work directly with hospital partners, making sure that, they're optimizing their data, making sure they're optimizing the partnership, really leveraging our solutions to meet the needs and improve care for patients. So really exciting opportunities within the organization.
Absolutely. Okay, so now that we're familiar with each other today, and before we dive into the meat of the content today, we'd like to ask our audience members today to tell us the challenges that you're experiencing in your trauma programs. So is it staying current, reporting technology, maintaining internal data quality programs, staffing, application of data, or a combination of those things? Or is it something else? And you can tell us by checking all that apply in the poll, or if it's something that's not listed here, you can submit your answer through the chat, and your answers are entirely anonymous to us. So feel free to let us know what challenges you're experiencing. Give it some time. All right. Well, I'll give you guys some time to continue to submit, but it looks like that main challenge that you all are facing is staying current, maintaining your internal data quality program, staffing, application of data. Really, all of these are, it's kind of a mix all across the board. So if we could end that poll, we'll share the results with you.
So, interesting. This is kind of what I expected to see. Most of our partners are reporting, these kind of challenges. Our organization works hard to make sure that we anticipate and meet the needs of hospital partners. In doing so, we did our own think tank, worked with some trauma centers that we partner with to explore, what was challenging and what solutions we could align. And what you're reporting today in this group really matches those results from our think tank. And you can see here the current state of trauma data. When we talk to our hospital partners, they share your sentiments, difficulty in staffing, maintaining staffing, some technology challenges, using, databases to upload and abstract data accurately. Not dissimilar to what we saw in today's poll. And this was a group of 14 participating trauma centers and all the members there who, were surveyed and reported. Staying concurrent is certainly a challenge. And using that data to impact care is what it's all about, and it remains challenging.
Absolutely. So with our poll results in mind, Beth Ann, would you mind kicking us off here by explaining how you are personally, as a Q-Centrix dedicated advisor, seeing our partners and other trauma professionals leverage trauma clinical data? And how have the methods changed in the last few years?
So how have they changed? That's a good question. The unfortunate answer is that there hasn't been a ton of change, right? So we're still treating trauma data as fairly obligatory, meaning that, we're kind of abstracting it in a just get it done mentality. It's a requirement for designation, and sometimes we lose, sight of the impact that data can have. So and you saw in the poll, both in our survey with our partners and then also in today's results, that it's still being, treated as fairly retrospective. So most trauma centers are still struggling to stay, greater than 30 days ahead. They just fighting off the idea of having a backlog. And so the concurrency of the data is still challenging. Of course, there's bright spots and all that, right? And I think we're sharing today, you mentioned the Grady case study. It's kind of a normalized deviance now that trauma data is just retrospective, and organizations like Grady kind of said, you know what, we're going to fight that status quo. We're going to challenge and see whether we can achieve concurrent data in a meaningful way, right? So it's concurrent, but it's also highly accurate. And I think the case study does a really good job of exemplifying their efforts. And, they should be proud of demonstrating that it can be done differently, and kind of fighting off that normalized deviance. Other things, I guess another point to mention is that trauma has a very broad definition, and what we continue to abstract in trauma is blunt and kinetic energy mechanism of injury. And so we're not even, today capturing the full scope of what is out there as really classified as traumatic injury. And so it's still a very limited subset of trauma data that we continue to capture. Of course, the pandemic has brought on a lot of challenges around staffing, case volume for trauma. Trauma is a disease that it isn't ever voluntary, right? So as we cut out voluntary procedures and we did things to decrease census, to shift resources, trauma is never voluntary, right? And so those volumes stay up. Sometimes you'll see a shift in mechanism of injury. So when everyone's not commuting to work, maybe motor vehicle crashes, numbers kind of declined. But then that shifts to falls, right? So more people are staying at home. We encourage people to go outside. That was one thing that you could do, and socially distance. And so, the shift from maybe not having a car accident, but maybe now an ATV accident, or you're hiking and you're falling, or you're riding your bike. And so as you kind of shift what the society is doing, you shift the mechanism of injury and trauma, but those numbers really never decline very much. And even in the pandemic, we saw high volume, complex cases. And then that is challenged with maintaining registry staff, right? A lot of organizations have abstractors who are working kind of with a second hat, right? So they're clinical resources. Maybe they take care of patients as their primary hat, and they wear a secondary hat to do abstraction. And so when you're shifting resources to the bedside, the privilege kind of being able to have them available to do abstraction too is minimized. And so, trauma departments are challenged with making sure they have resources available to do the abstraction work and do it in a meaningful way. And it's, like many other registries and other departments, there's that flux is causing inexperience and or lack of registrars at all. So those are, I think, some of the major challenges that, we're seeing as hospital partners, and, it's echoed in the results of the survey today.
Thank you, Beth Ann, for kind of walking us through those challenges. And as you mentioned, we will be sharing our Grady Memorial Hospital case study along with the recording of this webinar to all registrants. So keep an eye out for that in the next week. So as we all know, clinical data plays an important role in trauma, both at the micro and macro levels. Can you share some of the ways it affects trauma at a micro, or what we call the facility level?
Sure, absolutely. So, that's the main purpose of a registry, right? It is to measure care, quantify results, and give you meaningful information on which you can act to improve processes, to, ensure adherence to best practice, those kind of things. The most obvious then element of application is in setting your process measures and your outcome measures. So what elements of a process can you quantify and measure and affect elements of a process that will lead to a particular outcome, right? But these are the steps along the way that will help you achieve your goal. So if your overall goal is to, reduce mortality, you have to define elements along the way that you can improve as elements of care or processes, measure those, and then look to achieve, change in that, and defining those with data is really what it's all about. There's a lot of anecdotal information, right? And I have a sense that we have a problem here, but acting on anecdotal information is dangerous. Really making sure you have root cause and you have some quantifiable measure is important when you're doing continuous quality improvement and process improvement work. And no matter what format or recipe you're using, whether it's a Six Sigma, DIMAC model or a PDCA, all of those processes, right, to improve care are based on defining, measuring, in PDCA, it's called planning. And that's that element of understanding where you are so that you can understand, where you're headed. To look more specifically at some of the elements that are abstracted in trauma registries, you can look at, some of these SMART goals that we have listed here just as examples. So you're, abstracting information that can lead you to understanding how to decrease, your VTE rates, right? And what's your overall rate, right? That's an outcome measure. And who of that subset of patients who have VTEs, what's that demographic look like? Is it all your trauma cases? Is it a certain mechanism of injuries that you're seeing, a higher incidence of thrombosis in? Is it, when do these develop? Is it day 3? What elements of preventative care were provided? What's the adherence to those best practices? All of these elements are being captured in your registry and can be then, kind of examined on a micro level to determine, okay, it's, mostly our falls, mostly 65 and older, and they're getting it on day 4 of their hospital stay. And, you can backtrack from there and really determine how to affect care in a meaningful way to improve that outcome. Your blood plasma, right? So this is talk about process, right? So administering blood products is quite a process. Your documentation is an element in this. And so care and delivery and documentation are 2 different things that they want to be one, but that's still a challenge. And certainly in the complex blood administration records, right? The timeliness and if you're capturing that correctly. But, there's goals to ensure to stay out of the trauma triad, right? And to prevent coagulopathy and those kind of issues that are certainly related to increased mortality. You want to have a blood and plasma ratio that's appropriate. And so you're abstracting not only, how often you're using a massive transfusion protocol, you're looking at that match between blood and plasma. So many things that you can optimize in this process. Is the documentation convenient for staff? Are they able to capture the elements correctly? And then, as you're abstracting that, are you able to find those elements? And if not, does there need to be change in that process to ensure that you can accurately do so? You might be at a smaller facility who doesn't even have a massive transfusion protocol. And you might look at the data and say, you know what, we are transfusing multiple blood products to this subset of patients who present. Maybe it's not all the time. Maybe it's when the weather's bad and the helicopter can't fly, or there's a ice storm and you can't get a patient to a higher level facility in your trauma system. And so understanding those data elements that are being captured by your registry can really drive change. Serious complication rates, of course, your overall mortality rate might not be bad. Your serious complication rate might be, poor. So you might send your patient home alive, but they stay in the hospital, 4 or 5 days longer than they should. They have a, hospital acquired condition as part of their stay. So, comparing those 2 serious complication rates often do increase mortality, but not always, right? Sometimes they don't affect overall mortality, but you have the ability to affect change and improve care along the way. Another commonly abstracted element is those elements that lead to a better understanding of prophylactic IVC filter placement. Of course, we don't want VTEs, but we don't want to overuse a procedure for placement of a filter if it's not indicated. And so, making sure that you understand what patient population is most appropriate for IVC filter, and making sure your protocols and care regimens align with those kind of things.
And I think you would agree that the most important caveats for this all to work is that work can be meaningful is that it has to be timely and accurate. And that's something that we talk about a lot here at Q-Centrix because it's so critical to making sure you can get those insights out of your data.
Absolutely, right? If it's too retrospective, or if it's not accurate, the integrity of the data has to be there. And if it isn't, then all of these care decisions are based on flawed information. And, that's just a roll up of, error to create, more process issues. So accuracy and timeliness are critical.
Okay, well, I know you just gave us a whole list of applications for that data, but what if those are already being used? Are there any other less obvious micro applications for this data that our attendees can bring back with them to their organizations?
So yeah, I mean, important consideration for the hospital is most states have trauma funds allocated, and that those funds are dispersed in a way to provide compensation for uncompensated care in vulnerable populations, right? So you want to ensure that as you're capturing your state data, that it's accurate and timely, and reported to the state, and so that that information can be used to ensure that if your hospital could benefit from allocation of these funds, that you're capturing as much of that as you can. Certainly, as budgets are tighter, and as we come out of the effects of pandemic on healthcare resources, you want to be sure that you're capturing any funds that are available to be captured for your organization. And not every state has those funds, but the majority do. There is some recent published articles that infer that this data might be even more impactful, and that there might be more of a responsibility to capture elements in order to receive trauma funds. So that's an important piece to consider, especially with tighter budgets. And I guess the last piece I would kind of emphasize is what you can do with trauma data internally to drive education. How powerful is it to be able to identify a gap in either knowledge or understanding of a policy or understanding of a care element, be able to quantify that, share that information with the teams that you're educating. Every organization has mandatory trauma education to get done, and often it's just kind of, okay, what can we do to educate trauma? But how meaningful when you're tying that to some data. You have a pre-measurement, you're able to share the reason why you're educating on this topic. It helps engage the learner, helps to make the information meaningful, and when you do that, the retention of that information is greater. You provide knowledge and education on that, and then you can really remeasure and look at those metrics and see if that changed. Maybe education wasn't enough. Maybe you thought it was a knowledge gap, but really it's a process issue. And combining those efforts to create change is really important. So making sure that your educational requirements are done in a meaningful way is another way to use your data internally to impact your engagement of your staff and outcomes for your patients.
Okay, well, those are some really great insights, and hopefully a few of which you all can apply to your organizations. Now, Beth Ann, I know you are a big believer in the power of this data, not just for day-to-day activities, but also for influencing larger scale changes to healthcare processes, legislation, and more. Do you mind sharing a few of those macro examples and help give us some broader context and applications for this trauma data?
Yeah, absolutely. We think about, kind of registries were born, and we're working to use this data internally to improve care, but trauma is a social disease, right? So this is a public health concern, always has been, and we're learning more about the impact of public health through the pandemic. But the influence that this trauma data can have on things like decreasing the burden of disease on society, legislation, policy creations. You'll notice that there's different seatbelt laws, different helmet laws, state by state, and that's because there's no national trauma system. Each state is responsible for that, and each state then collects data and influences state policy based on that information. So, there's still some states that don't have motorcycle helmet laws, and understanding the demographics, the incidence and prevalence of motorcycle crashes that result in head injury really helps to drive those kind of decisions. It also drives the consequences for breaking the law, right? So the severity of the consequence is sometimes based on the data and what's provided, and those kind of things are really interesting and often not things that we think about. So, back to the integrity of the data, because this data can influence those kind of decisions. Again, whether you're in trauma or you're not in trauma, as a member of society, you really want to think about and hope for the fact that that data is accurate and it has a high level of integrity. Right? These decisions, kind of global decisions, are being made on that. Car manufacturers use data to help, improve the design of vehicles, anywhere from, hood angles and front grills for pedestrian struck, airbags, where they should be, what their deployment looks like. I just recently got a new vehicle, and I noticed that there was this safety feature that if your car door was open, it disengaged drive, which I was just super excited to see, because I had a number of patients in my bedside career that stopped at a mailbox and took their foot off the brake, and the car rolled and they fell out, or they're at a drive-up window and they forgot to put it in park. And so, in my mind of seeing traumatic injury from that cause, it was really cool to see this new element in the car design as a safety feature. So those kind of injury summary, mechanism of injury, demographics, that information feeds a lot of product safety and design, particularly in the auto manufacturing space. It also drives things like your injury prevention campaigns. So your kids' bike safety fairs, those kind of things. There's a Stop the Bleed campaign now, and that was based on information that was kind of aggregated from trauma data, right? So we know that excessive bleeding pre-hospital changes outcomes. And so, looking at the application and the literature around tourniquet application, this is a public health initiative that it is safe to apply techniques to stop bleeding in the field that before a professional arrives that significantly impact mortality. And so there's an initiative to expand community knowledge on, stopping the bleed. Falls, geriatric population falls, outreach into community, those kind of things. You'll see, I'm sure we've all seen images of like the pillars that come up out of the ground right before the crosswalk, those added features where pedestrians are constantly being struck in this crosswalk for all other measures have been exhausted. And so now they're moving to like more of a forced function where a pillar actually comes up when it's a pedestrian time to cross the street. So trauma data can influence all of those things that we see in our personal lives and in our community, which is, pretty cool application for data. And I guess the last thing to mention is, of course, the attempt to create, at least at the state level, a trauma system and regionalization of trauma care. And so the data is really important to help ensure that as trauma centers either progress in level, right, from a 4 to a 3 to a 2, right, up to a level 1. And then what's the geographic location? Do you have the amount of resources you need? If trauma kind of demographics and data isn't used to drive those decisions, it's often left to individual hospitals to decide. And there might be other reasons that they're incentivized to create a trauma center outside of the fact, of whether or not it's really needed geographically. So you can have an overpopulated area of trauma resources and then leave other portions of the state or geography underserved. And so understanding that regionalization is really important. And of course, the trauma data that is abstracted and aggregated at the state level can impact those decisions.
Thank you so much for those incredible macro examples there. So as a reminder to our audience, if you have any questions for us about any of these applications, please don't hesitate to pop them into the Q&A. It looks like we already have a few great questions that we'll address shortly. But based on the challenges that you mentioned earlier, as well as the results of our earlier poll, what do you suggest to our audience members do to solve some of the more common issues that they may face with their trauma data? And what are some of the best practices that you're seeing with our partners?
So best practices, I think, we're looking at across the healthcare spectrum is investing in people, right? Investing in the resources to have strong registry programs. And that's a commitment. It's an investment, not only financially for an organization. So, rather than having this second hat model where when resources got tight, there was no one left to abstract who was qualified and really good at that. So investing in, the resources of permanent staff to do that work, so it's not kind of ad hoc. It's financially an investment, of course, but it's also, an investment from a leadership perspective. So having engaged teams, hiring, maintaining, ensuring that they have the education, they're up to date on all the data elements, up to date on the reasons why their work is important. Those things are really important. So putting a strong emphasis on team and individual members who can abstract at a high quality is obviously a first best practice. Secondly, creating this idea of a national trauma system, right? Leveraging relationships between and across systems inside of the industry. So, maybe your leading mechanism of injury in your urban setting has always been motor vehicle crashes. And now all of a sudden you're starting to see, an increase in falls. And so tapping into another system whose leading mechanism has been falls for years, and they've really perfected their policy, their care elements, all those things around falls, and then sharing that information with your organization and really leveraging those systems and resources in the trauma community is an absolute best practice, as we can learn from each other. And then, of course, working hard to achieve concurrent status. And like Grady has shown in this, case study, it is achievable. And so, how do you get concurrent? How do you make sure that the data is, accurate? How do you develop an inter-rater reliability process? So you have an internal process to review your data abstraction and that you can demonstrate that your data is accurate and timely. Of course, the ACS has that requirement as part of their designation, but building that into your program and making that robust. It's an added resource, right? So now you're abstracting, but you have to have some mechanism to check that quality, and that check is an added commitment and resource. But hopefully, talking through all these micro and macro elements, it's obvious why the integrity of the data is so important.
Absolutely. So I am going to kind of close this out with our final question for today, and then we'll head into our audience Q&A. So we've covered a lot of information about trauma, clinical data use cases, best practices, challenges, and more. And based on everything we've talked about so far, where do you see trauma programs headed in the next few years?
So, I like this slide. We're trying to tell a story, right? And so, ACS's goal for a long time has really been to create, the National Trauma Database, this large national data set that can be aggregated kind of beyond geography of each state. And of course, that large scale data gives you that much more information. And so, we're taking these data elements, these individual Legos, and we're trying to build out a story from that. And the more that we share our bag of Legos, we can build, the house, the city, the whole picture of what trauma looks like in the United States. And then we can allocate resources appropriately to support that care and that expertise. So I think that is, a future goal that we all share in trauma, and certainly that the ACS is in support of and driving towards. The other piece that, maybe the future of data is that, I mentioned earlier that we still are very kind of micro focused on certain mechanisms of injury. Now, trauma is defined by the transfer of energy to the body in excess to cause disarrangement in the body systems. And so we look at kind of kinetic energy only. This is your blunt, your penetrating trauma, your falls, your motor vehicle crashes. We still are very focused on that subset of the entire definition of trauma. And so, there's opportunity to explore, thermal energy transfer, chemical energy transfer is, overdose, those kind of things are technically become by definition, are a traumatic injury. And so, expanding really beyond that singular focus of energy, of kinetic energy, and looking at other kinds, electrical, thermal, chemical, and capturing data around those mechanisms as well is certainly a future opportunity for trauma data abstraction. And then I guess lastly, I would say, every organization is on a high reliability journey. They're working towards establishing processes that are, proactive, that are data driven, and certainly aligning, the great work that trauma departments do, and really giving trauma departments in a lot of cases really could set the example for the rest of the organization on how to achieve high quality data that drives their processes. They're very tight processes in most trauma programs, and so they can really set the stage for that. But high fidelity data, again, you want it to be accurate because you're basing changes, you're informing care around the data that you're collecting, but it can help with HRO principles like, anticipating failure. You can look at your metrics and look at your data, use it to be proactive in the way you organize your care. Certainly using it to inform operations, ensuring that there's a sensitivity to operations, to how trauma care is delivered. And data really helps to prevent the oversimplification of cause. It really allows you to dig into root cause. I mean, you can look at even time of day and day of the week and weather conditions, and all these micro elements of the data can help inform your decisions and ensure that they're accurate, so that when you put in the effort to make a change and when you ask your teams to engage in the work, it isn't just like another thing that we're going to try. We actually know that this is going to be beneficial, and that's, I think, another big element of what's to come in the future. Really, again, using the data proactively to improve care and to mitigate risk and prevent harm.
Thank you so much, Bethan, for sharing all of this incredible information and lending your expertise on the importance of trauma clinical data. We have about 20 minutes for audience Q&A. We might let you out a little bit early, but I see a few questions have come in. So if you have something on your mind you'd like to ask Bethan, please send that question into the Q&A button located in your participant controls. And if you see a question you'd also like answered, feel free to give it an upvote and we'll try to prioritize those questions. So I'm going to start with a question. What are some best practices for hospitals trying to obtain higher trauma designation, and how can Q-Centrix help in that process?
All right, well, that's a good question. So best practices in changing level. I would emphasize the accuracy of your data. So how can Q-Centrix help with that? We have made the investment and the commitment in people and in teams and in ensuring that we have high quality, engaged, trained registrars who are updated in information and educated and maintain their knowledge. And so how can we help with that? We can help with the integrity of the data. We can help with the timeliness of the data. And certainly, then as that data is applied, should you be the next level of trauma care? Are there 3 other level 2s within your area? How do you determine whether that next level of care is appropriate based on the demographics of your area and the incidence and prevalence of trauma and trauma injury? And so, having accurate data and analyzing that across a geography, understanding why do you need to bump your level of care? Is there a patient population that's underserved? Do you have a mountain range between where you are geographically and the level 1 hospital? And, 9 months out of the year, the weather is challenging and you have trouble getting your patients to the level 1 facility. And therefore, you're keeping them in-house and your outcomes don't reflect what you want. And is that a catalyst to consider moving to a level 1? Those kind of things. So Q-Centrix can help in a lot of ways. And certainly the data then can help drive those decisions.
Okay, move on to our next one. How can trauma registry data be used for TIC?
Trauma in trauma-informed care. That's an interesting question, and it is probably a kind of a secondary application for registry data. So trauma-informed care is really flipping the lens on overall care that's provided by a hospital system. And so it is kind of widening that lens. So a lot of times we think of trauma as a very tight subspecialty. In your larger trauma facilities, you'll have, very focused units and processes and systems, and the trauma patients are only, cared for in certain locations within the hospital. In some lower leveled facilities or a non-designated facility, trauma might end up from the ED anywhere on any floor in the hospital. And so that subspecialty of care is a little bit more diluted. Trauma-informed care really looks beyond just that acute care element. And so registry data could help to inform the allocation of resources, let's say, for your organization. So understanding this broader impact of trauma. It can be used, to kind of open the mindset that trauma isn't, trauma kind of is everywhere, right? And so it can help inform your triaging processes, your admission processes. It can be subtle, it might change a triage question or an admission question from, what's wrong with you to what happened to you. And just that subtle verbiage change can really open up the answer that you might receive. And so you might realize that there's pockets of trauma that don't necessarily present as trauma as the primary cause of entry into your facility, but there are traumatic elements included, and helps the hospital kind of, I guess, understand how to assume trauma is in more areas than just when it's kind of overtly presented to your facility. And, resources around kind of opening up that is, what about your resources for social work or, your support groups? So trauma-informed care is beyond that immediate acute phase, looking how to support people when they go back to the community, how to support families who have been through trauma, and not just the patient themselves, but the larger group of people that this one individual trauma affects, right? And so I think registry data probably can inform on demographics, mechanism, location, those kind of things to help the hospital and hospital system understand trauma more globally.
For that. We've got a couple more. So could you please provide an example of using DMAIC and registry data to improve care?
Okay. Well, let's go back to the blood transfusion, right? And so your, DMAIC is your Six Sigma kind of process for quality improvement. It starts with define and measure. And so let's say, you're an organization that doesn't have isn't delivering the ratio of blood to plasma that you want. So, the first step is defining. So that's pulling, information that you've abstracted, and now you have some, summary information to take a look at, and you're seeing that, you're giving 4 units of blood and then maybe 1 of plasma, and then that's the cycle you're repeating. So you have a defined goal, you have a measurement, a pre-measurement, and then you're analyzing, okay, where's the breakdown here? Why do I not have the right ratio? And you're kind of analyzing the process, taking a look at it. Let's say you discover that the cooler that's coming up has, it has 4 units of blood and 1 unit of plasma, and so your design is flawed because the cooler comes and you're hanging what's in the cooler, and so that's an immediate easy fix. The design is flawed. You reorganize. You work with blood bank across departments. You reorganize the way the cooler is packed and delivered. Maybe there's some layers in there so that you can top down, make sure that you provide it in order, make those system changes, and then you implement that, and then you measure, right? And you get the opportunity to use that same data set that you collected to define your process in the beginning, to really give you an outcome once you've made your change. And now you see that, oh, look, when we call massive transfusion with this new cooler design, we're given 2 blood products and then before we give a plasma, and immediately you can see a result. So you got to have the data, right? You got to be able to quantify your starting point and your ending point. I hope that was a good example.
Okay, well, here's the one. Not sure if you can answer this, but when do you think AIS 15 will be mandated to be implemented?
That is a good question, and I do not know the answer to that. I don't want to speculate because I don't want to give out any misinformation. So I would have to do a little research on that to provide an accurate answer.
No problem. Then I have one more as of right now, unless a couple sneak in, but what is your perspective on TQIP participation? Is it necessary and valuable?
Well, I'm a data junkie, so I think all data capture is valuable. Is it necessary? Arguably, I guess you could say it's not. I think, though, that it's a program that's supported. It's kind of like an evidence-based practice. Best data elements to be captured that can drive significant change. And so, if you think about all of the information that's put into an electronic health record, what data elements are most valuable. And so, ACS, TQIP, they're taking the effort to define the data elements that can have the greatest impact on care. It also kind of organizes information. If we're all abstracting the same information, then that data set is larger. And so, yes, absolutely. I think it's valuable. I think that a lot of effort is put into ensuring that there's thought behind what data elements we capture and why. And so I think it's a valuable add.
Thank you, Beth Ann. That is actually the last question I have. So I'm going to conclude our webinar from micro to macro, the importance of trauma clinical data. Thank you to everyone that's joined us today. And thank you, Beth Ann, for sharing your expertise on the importance of clinical data. If you have any more questions, feel free to send them to bmendez@qcentrix.com, and she'll be sure to respond as soon as possible. As you exit this webinar, you should see a link to a survey pop up in your browser, or you can click on the link that I'll pop in the chat now. Either way works, but we encourage you to complete this to let us know if you found this discussion of value. It should take you less than 2 minutes and would help us greatly. And finally, as I mentioned before, we'll be sending an email with a recording of today's webinar along with our Grady Memorial Hospital case study to all registrants within the next week. And that's all for today. So thank you so much and have a great rest of your day.
Thank you.